second. Welcome very much to the MOLI dissemination meeting, and thank you for joining from all over. We've got 20 or so people here at Liverpool Medical Institute, but the majority of people are online. We've got something like 120 people booked, so please keep yourself on mute so that we don't run into any problems that way. I'm just going to make sure that you can hear. I think you're going to be able to hear everyone. It may be just not us who can hear. But I think Pete, the Dean of Institute, is on standby to come in, hopefully.
Yeah. Can you hear me yet?
Okay.
Andrew, obviously not.
Okay, that's fine. Okie doke. So, welcome everyone. My name is Andrew Weeks. I've been the chief investigator for this MOLI project, and it's great to see many of you here in the Liverpool Medical Institute. Liverpool Medical Institute is a very interesting place. It's one of the oldest medical societies in the world. It dates from 1770, would you believe it? So it started out as a journal club. So anybody starting a journal club, you never know what it's going to turn into, because it became a library and people started getting together as a library. And then finally, they decided it needed not only a library, which was transportable from place to place, but a building. And so they built this place in 1837. It is really the center of the Liverpool medical community. If ever anyone gets a chance who's online to come and visit Liverpool, come and see the Liverpool Medical Institute. It's quite historical. We've been going for little tours around earlier on. It's got, for those of you interested in obs and gynae history, both Bear Blell, who of course was founder of the Royal College of Obstetricians, and Norman Jeffcoat, who people might know from his textbook, are also former presidents here. So, without too much ado, I'm going to hand over to Professor Peter Clegg, who is the Dean of the Institute of, let's see if I can do this, if I can click on, there we go. So he's Dean of the Institute of Life Course and Medical Sciences, just to say a few words of welcome. Pete, can you hear?
I can hear you fine. Can you hear me?
We can hear you very nicely.
Brilliant, it's working. So first of all, welcome to Liverpool, everybody, or either virtually or in person. I'm Professor Pete Clegg, so I'm the Dean of the Institute of Life Course and Medical Sciences in the Faculty of Health Life Sciences at the University of Liverpool. And it's one of the larger research and teaching institutes because it contains both the School of Medicine and the School of Dentistry, as well as 4 large research institutes, research departments, which is musculoskeletal, cardiovascular and metabolic medicine, eye and vision science, and women and children's health. And obviously Andrew sits in women and children's health. We're a relatively large institute with about 2,500 undergraduate students and about 300 postgraduate students. Well, the staff count is quite large because we have a lot of part-time medical teachers. We've got nearly 1,000 staff, but a lot are on part-time contracts because they're working a lot in the health service. You know, it's a relatively large institute. We've got a research income of about £30 million a year. We're sort of really proud of our work in global maternal health, and that sits within the Department of Women's and Children's Health. And this work is really led by Andrew Weeks, who's obviously leading here today, and David Lissauer. And we've got sort of projects variously around the world. Within this work, you know, Andrew has worked with Genuity Health Projects on misoprostol research for over 20 years. And this has been a very productive collaboration for the University of Liverpool, particularly in collaboration with Professor Mundal from Nagpur in India, and exploring the use of oral misoprostol for induction of labour. And this has received 2 large grants in the UK from the UK government and the Medical Research Council, as well as the Wellcome Trust. We're really delighted to have everybody here today and welcome all our visitors, particularly those from India and the USA. And I'm sure that, the time zones are slightly challenging with our spread around the world here, but I'm delighted you can all be here. And I think it's going to be really exciting to see the results of this second major randomized trial, the MOLI study, which is set up to explore new ways to improve the effectiveness and safety of labour induction. So I think we're all very excited to hear this data. Welcome to Liverpool, and I'll now hand over to Andrew Weeks to talk us through the programme of work. So thank you, Andrew.
Thanks so much. Thanks so much, Pete, and thanks for all your support over the years as we continue our global health work. So we've got a programme this afternoon whereby we've got here is our list of speakers. So I'm going to tell you a bit about the background. Why on earth are we studying this? What's all this about? Why is it important? Then we're going to have speakers talking about what happens in India at the moment. We've done a situational analysis as part of this program of work. We're then going to go on to the results from the randomized trial that we conducted. We'll talk both about clinical results and about health economic results. And then we'll go on to the qualitative results as well. And finally, we're going to have a presentation on a new outcome index that we've been exploring as part of this. We've been piloting. And then finally, we'll come on to a panel discussion. And we're very grateful to Sabaratnam Arukumaran and Andrew Shannon and Moshmi Tadas for being on the panel. So there have been, I said this is a program of work, and there's been a huge number of people involved in this. Both from the University of Liverpool, we've had a number of senior academics working on it, but also more junior staff. There's been medical students who have joined us, junior doctors, as we've gone along, and all have contributed. But then, of course, we've had the partners in India and the 3 hospitals from Government Medical College, Dagger, and Mahatma Gandhi Institute in Serakam. Who have been running the study itself. And then, of course, as Pete mentioned, the collaboration with Genuity. And thank you, Beverly and Jill are both here today, so welcome to you as well. And Shuchita and Jaya are also here as well from Nagpur. And then Simon Lee is going to speak to you later. And thanks, of course, to the Trial Steering Committee and the Data Monitoring Committee. And I think people are, some are been able to join the call. So why are we interested in oral misoprostol for induction of labour? Well, I'm part of I do a Cochrane review. Everyone who goes in Liverpool, because we're the centre of the pregnancy and childbirth group, we all got involved in Cochrane collaborations, and my particular interest on oral misoprostol have ended up leading this review. And in fact, comparing oral misoprostol as an induction agent to all the other ways in which you can induce labour, it actually turns out to be pretty much the best of them all. So our conclusion, we just did a review. Robbie Kerr, who was a junior doctor with us at the time, did this review in 2021, and actually looking at all the studies, low-dose oral misoprostol seemed to have lower cesarean sections than the other routes, and very low rates of hyperstimulation. And both those are critical things when you're inducing labour. And if you that's the case if you compared it to the standard that we use in this country, vaginal dinoprostone. If you compare it to Foley catheter, which many units use, actually that's known as the low hyperstimulation, but actually it had equivalent rates to it. So the level of hyperstimulation is right down with those. But in fact, it had lower cesarean section than used for Foley catheter, which our previous study showed. Many people have used low-dose misoprostol vaginally, but in fact, orally seems to be the better route, both from a maternal perspective, but also there's less hyperstimulation if you give it that way, and lower cesarean sections due to fetal distress. So there's all sorts of reasons why oral misoprostol is the product of choice at the moment. But what about in India? Well, in India, actually, the FOGSI induction guidance from 2018 doesn't recommend induction of labor with oral misoprostol, although it is registered with the Central Drugs Standard Control Organization for cervical ripening, and also in the FIGO recommendations as well. Our NICE guidelines on induction of labor came out just at the end of 2021, so just over a year ago. And they, for the first time, said that for a woman with a Bishop score of 6 or less, we should be offering induction with dinoprostone as a vaginal tablet, which is what we've been doing as a standard, or vaginal gel, or controlled release vaginal delivery system, or with low-dose oral misoprostol tablets. So that's brought around quite a change in the UK. But there's something interesting. Whenever you look at how you're going to induce, are you going to induce with whichever tablet you use, what's tended to happen is that you start off the process with that, and as soon as the membranes rupture, you change over to a drip of oxytocin. And pretty much every study has been doing that. However, if you, I did some work with Žarko Alfirović a couple of years ago, and we went through all the different studies, and you can see actually how, going back, these are all the published trials at that point, but continued in the active phase? No, most of them just changed to oxytocin, and that's what we'd be used to. But there were a few that actually, and it's all pioneered by Justus Hoffmeyer in 2001, if augmentation was required, instead of changing to oxytocin, they continued with the oral misoprostol. Now, that's quite a revolutionary thought. And in fact, these other ones were groups who are closely associated with Justus, and it does seem to work very well. Now, that seems a little bit odd, because with oxytocin's a great faff for anyone who's used to doing it. You need an infusion, you need an infusion pump, you need to titrate the dose very accurately as labor progresses. But what you're doing with misoprostol, what we're suggesting is that you can just give the same dose every 2 hours. So it's quite revolutionary. It's not an infusion, it's a tablet. It's given every 2 hours, given. Some of these, they've titrated the dose a little bit, but most of them, they've just continued with the same dose. So there could be great benefits in removing the oxytocin as the second half of the induction process. Oxytocin, of course, needs drug refrigeration, which misoprostol doesn't need to. It needs an infusion pump to try and get it an accurate infusion. If you took away oxytocin, potentially it's less intensive for the staff, because instead of continually checking the infusion pump, you could then just give the standard tablet every 2 hours. There'd be increased mobility of the women being induced. There's potentially less hyperstimulation, although we wanted to test that. Would it be more acceptable to women? Well, actually, that seems to be cultural. We'll come back to that. But certainly for people in the UK who don't like injections, they prefer to have a tablet if possible. It's shown greater acceptability. But on the other side, could this be too perfect? There's already a lot of oxytocin used worldwide. Actually, could this be a problem? Could it make augmentation too easy? And so from a public health perspective, could become a problem. So we set out to test whether, once you'd given oral misoprostol to start with, do you need to change across? So if you look at our plan here, we started with consent and recruitment, and we recruited women with hypertension to the study. They all got misoprostol every 2 hours, but then once they ruptured their membranes, either spontaneously or artificially, we waited 30 minutes to see what happened, because many people just go off into labor on their own at that point. But about 50% actually need to then go on to have some kind of augmentation. At that point, they were randomized. They were randomized either to receive oral misoprostol every 2 hours or an intravenous oxytocin infusion, which is the standard. Now, we'll come on to the clinical results in a minute, but actually, as I said earlier, there was a bit of a program of work. So we've done a situational analysis, which we'll hear about next, to find out what was the standard practice in India. We did the randomized trial, we did a qualitative study as part of it, and this pages index Rachel will talk about a little bit later. So with that as background, I'm going to hand over now to Jill DeRocha from Genuity in the US. So she's senior director of Genuity Health Projects. Thank you so much for making the trip across, Jill. We're looking forward to showing you a little bit of Liverpool. Let me see if I can get this right so that I can swap this across to your slides. What we'll plan to do is have, where am I going to? There we go. How's that? Has that changed across? Oh, no. Sorry, that's gone right through there. Perfect. Okay, and so what we'll do is have 10-minute presentations then with 5 minutes for questions at the end of each one. Jill.
Thank you. Good day to everyone. Thank you for joining. It's nice to be here in Liverpool with the team. This has been a long collaboration and a long project during COVID, and it's nice to finally be able to see people in person here. So thank you for all of you joining remotely. We look forward to sharing these results with you. So as Andrew was mentioning, along with the clinical study that we wanted to conduct, we also wanted to know more about the contextual, the context in relation to induction of labor methods. This situational analysis was done in health facilities in Nagpur, excluding the 3 study sites that were in part of the randomized controlled trial. So with this, we had many partners involved in this work, and we have our partners in India, and also along with our collaborators in Liverpool here as well. So the main aim of this situational analysis was to assess the current available resources, the current policies and practices related to induction of labor methods. Again, this was just looking at sites in Nagpur. This is not a representative sample among sites in India, but really just to help us understand the context better so that we can help shape our dissemination and sharing of the results based on the clinical trial results. So this research, a landscape analysis, had several components. We had a review of the documents the policies related to the induction of labor practices. We conducted key stakeholder interviews to know more about their opinions and current policies and practices on induction of labor in India. And these key stakeholder interviews were, stakeholders within India in many different positions and places. And then finally, we had our site assessments, our facility assessments, and interviews with providers at each facility that was part of this situational analysis. And this included public and private healthcare facilities, along with pharmacies in Nagpur district. So first, just to share a little bit of what we learned about the Indian guidelines on misoprostol for induction of labor. Well, first, we know in the guidelines that they support use of uterotonics for induction of labor only at hospitals where facilities for cesarean section are available. So in our situational analysis and our facility assessments, we were focused at secondary level hospitals or higher, both public and private. We know that from the FOGC guidelines that oral and low dose vaginal misoprostol is recommended for cervical ripening. It's supported as a cervical ripening agent. However, misoprostol is currently not included in Indian guidelines for the augmentation of labor, which is the purpose of our clinical trial results. So with regard to the sample, as I said, it's not representative, but it helped us to understand more about the context in the area where our trial was being done. So we had one urban district subdistrict of Nagpur city. And then we had 5 nearby rural subdistricts included. And so within each district, we worked with the public facility that was secondary level or higher. And then we also had, we selected 15 private facilities. This was a random selection based on a mapping exercise within the urban district, along with 10 private facilities in the rural districts. And within each five rural districts, we selected two private facilities along with the public facility. So in total, 31 hospitals were visited. So just to give you a snapshot of the facility assessments, in the end, 25 of the 31 facilities were practicing induction of labor in the past year. So among those 25, we asked about the resources available for providing induction of labor. So all of these sites had a senior obstetrician on site 24 hours, 7 days a week. As we would expect, 24 of these sites had the capacity to perform cesarean section 24 hours, 7 days a week. What stands out to us more in this assessment is that only a third of these hospitals had guidance or a protocol on induction of labor that was available. All of the sites had a handheld fetal daptone for monitoring during induction of labor. All of the sites had oxytocin, which is not surprising. Oxytocin is used for other indications. But again, what stands out to us here is that less than half of the sites had an infusion pump for the oxytocin administration. So this is definitely an important finding to keep in mind. When we look at the other induction of labor methods, 2/3 of the sites had 25 microgram tablets of misoprostol. Dinoprostone gel was also available in 2/3 of the sites. The pessary was not. And then again, we can see that 3/4 of the sites did have Foley balloon catheter available at the facilities. So at each facility that was visited, we also, the field workers were also visited either the drug, the pharmacy that was available or located within the hospital, which was in the drug shop at a public hospital, or they visited a pharmacy that was near to the private facility. So at the pharmacies, we also wanted to know what were the methods that were available and sold. So we can see that oxytocin and Foley catheter were available in these pharmacies. Oxytocin at 71%, and almost all of the pharmacies visited had Foley catheter. But what stands out again to us is that the misoprostol 25 microgram tablet was only available in about 1/4 of the pharmacies, and then dinoprostone gel was available in just a few more than that. So again, we're seeing that not all induction of labor products are consistently available and sold at pharmacies. So at each hospital, we also conducted provider interviews with providers involved in the labor induction process. The majority of the respondents were senior OBs and medical officers, along with some other staff there. We asked them which methods were preferred for cervical ripening. And this was, just to get a sense of their most common preferred options, and many methods could be mentioned. But we can see that misoprostol and dinoprostone gel were the two that were most commonly mentioned as preferred for cervical ripening, followed by oxytocin and Foley catheter with fewer. And then for labor augmentation, nearly all providers confirmed that oxytocin, IV oxytocin, was their preferred method, and one provider only specified misoprostol for labor augmentation. We also wanted to assess just how many were currently using misoprostol as their standard of practice. 55% said they used misoprostol for their standard of practice. So we asked about the routes that they typically used. 100% of those who use it as their standard practice administer it vaginally. 44% said orally, and a fewer said sublingually. We also assessed the dose, the tablet dosage. The majority said 25 microgram tablet. And then we also assessed the frequency of administration, and the majority said that they administer a low-dose misoprostol, vaginally mostly, 4 to 6 hours. So this is actually following the guideline that's put forth by the WHO. And then we also, inquired about those who do not use misoprostol as their standard of practice. Why not? 71% of those said they had concerns about adverse effects. Some providers said that it's not included in hospital protocols or guidelines, and then fewer said that it's not consistently available. So the takeaways from this, and again, these are takeaways that we want to kind of ponder as we hear more about the clinical results today. But overall, just in general, there's the need for further dissemination on the latest evidence and recommendations on misoprostol for induction of labor. I mean, misoprostol is already in guidance for induction of labor for cervical ripening agent. And even with that, there still seems to be a lack of knowledge of that in some places. And actually, I mean, the one thing to keep in mind is providers they did say that they preferred misoprostol as one of the most commonly preferred methods for induction of labor. However, the tablets were not found consistently in pharmacies. And so there's more work to be done. And also just to mention about those pharmacies that were not, where the tablets were not consistently available were in the rural districts as opposed to the urban district. So again, we should focus more on trying to expand the availability of the low-dose misoprostol in rural areas. Providers were familiar with its oral use, but appear to be using it more frequently vaginally in every 4 to 6 hours. And then again, that there needs to be the concerns by providers about the adverse effects need to be addressed through additional training and dissemination of the results. As part of the situational analysis too, we did just generally ask about suggestions for improving the performance of induction of labor at the facility. In their responses, the need for training and protocols were mentioned, better monitoring, more staff for monitoring, and better strategies for ensuring that patients are monitored during the process. Providers also mentioned the need for additional resources, manpower came up again, medicines in the facilities to offer cesarean section. There was also the mention of a blood bank being available at these hospitals. And then lastly, that improvements to the counseling of patients and families. This is another area that's come up in some of our qualitative research as well, that there's just the need to have better counseling and better education of patients and families with regard to the labor induction process. Thank you.
That's fantastic, Jill. Thank you so much. Any questions? I think we can take questions online or from the room. People in the room would need to come up to one of the microphones. If you're online and you want to ask a question, either put your hand up or put in the chat box. There will be a chance for questions later on. If there's nobody immediately, we can move on to the clinical results.
We have a question online.
You have a question online? Okay. So I think we're going to unmute whoever's got the question online. Is the 25 microgram preparation available in India? Is the question. Okay. Do you want to answer that, Jill?
Probably one of our Indian partners could answer this better. It is available. I believe there are more than one product. Yeah. It's available and sold in pharmacies. It's just not consistently available, but there is a low dose 25 microgram tablet available in India.
So Cipla is a huge drug company in India, and they make a preparation. They have done for many years, I think, ever since we've been studying it, really. There's probably others as well. other providers are available. I should say that. Another question, any difference between public and private facility choice for method of induction? Do you see that?
Yeah, that I don't believe there was any. I mean, our sample was pretty small in that respect, but no, nothing in our data would suggest that there was a strong difference, you know, with any providers preferring, you know, one over the other. What just stood out to us was the preference, the common preference was for misoprostol and dinoprostin.
Okay, so we've got a question from Debbie Armbruster. Debbie, can you come in?
Sure. Can you hear me?
We can.
Okay. So the question I have is, given that misoprostol is the preferred choice and you aren't finding sufficient 25 micrograms, did you find that they were breaking tablets up and using pieces, or using the what I call the Justice Hoffmeyer method of actually dissolving a 200 microgram tablet in water? Just wondering what they did and what you saw. Over.
Thanks. Just unmuting. Thank you, Debbie, for that question. We didn't, our surveys didn't collect that type of information on what, you know, if they were dissolving tablets. Really, we were asking specifically about 25 microgram tablets being available, and if they were using them. And so we know from our survey that when they were available, they were using it. But also, I think the question was asked that even if it's not available, what is your preferred? If it's not always available, but is it your preferred method? So, but yeah, we did not ask about, you know, dissolving the tablets. That did not come up in the survey.
Okay, thank you. I'm afraid we need to move on. This is fascinating. We could have a whole afternoon on this, but we do have the results of the trial to move on to. And so thanks very much, Jill, for that. And I'm going to call on Professor Suchita Mundle, who's going to give us the clinical results from the MOLI study to see whether, in fact, you can replace the use of the oxytocin with misoprostol. And see if we can. Thank you, Professor Mundle.
A very good morning to a good afternoon to all. At the outset, I'd like to acknowledge Professor Pete Clegg for presiding over this meeting. It's indeed an honor to be over here at the University of Liverpool and at the Liverpool Medical Institution to present the results of the MOLI study. And it has been a pleasure to meet the entire team of MOLI in person after a long time. So I will be presenting the results of the randomized trial comparing oral misoprostol alone with oral misoprostol followed by oxytocin in women induced for hypertension and pregnancy. So we have an acronym for this as the MOLI study. So that's what has been going on around, the MOLI T. So here we are. So as has already been highlighted by Andrew, this is a collaboration between the University of Liverpool, Geneti Health Projects, and a number of institutions in India, based in especially in Nagpur and nearby. So this trial was supported by a grant from the MRC and the Wellcome Trust as a joint global health trials fund. So in brief, the study protocol, after cervical wrapping with oral misoprostol, we wanted to know whether augmentation using oral misoprostol was superior to the standard protocol of intravenous oxytocin. So we consented and recruited women to 25 micrograms of oral misoprostol in a 2-hourly schedule. Women underwent a vaginal examination every 4 hourly to see the status of the cervix. If the cervix was favorable, either artificial rupture of membranes was done or patient had a spontaneous rupture of membranes. We waited for another 30 minutes for the patient to go into spontaneous labor. If not, then the women were randomized at that point to either oxytocin or misoprostol. So the randomization was into 25 micrograms of oral misoprostol given in a dose of 2 hourly or intravenous oxytocin titrated every 30 minutes as per the protocol to a maximum of 20 millunits per minute. The outcome was vaginal birth. So this was an open label randomized superiority trial. The study sites were JMC Nagpur, Daga Women's Hospital in Nagpur, and MGIMS Sevagram. We had a sample size of 520 women, and the primary outcome was the rate of cesarean section at birth. So Nagpur is a city situated in the center of the country, which has a diverse population, both in the urban and the rural setting. So women were included into the study if they had a live fetus with intact membranes. The indication for induction was hypertensive disorders. If she was more than 18 years of age, who gave an informed consent, where misoprostol was used for cervical ripening, and the decision to augment labor for inadequate uterine contractions after membrane rupture was taken. So we excluded women who had a previous C-section scar, who had a multiple pregnancy, or where cervical ripening was done with any other agent other than miso, especially if Foley's catheter or prostaglandins were used, and women who could not give a consent. So we screened about 3,650 women for induction of labor, especially for hypertensive disorders over a 2-year period. We did not include almost 2,000 plus women because they had various reasons where they did not meet the inclusion criteria. So our recruit was about a cohort of 1,033 women who were consented, and amongst them, about 520 were randomized. In this cohort of 513 were women who were not further randomized either to oxytocin or misoprostol. So at the end, we were with 260 women in each group, either misoprostol or oxytocin. All participants used the assigned method, and the analysis was intention to treat. So coming to the background characteristics of these women, they were similar for age and the gestational age. The mean age was about 25.2 to 25.6 in both the groups. The mean gestational age was around 38.7 to 38.8. The mean diastolic or systolic blood pressure as entry was 140 and 139 in both the groups. The mean diastolic blood pressure at entry was about 92.6 in the miso and 92.2 in the oxytocin group. There was proteinuria and enrollment, a significant proteinuria in about 20% of the cases in both the groups. So mainly these women were gestational hypertension, you could call them. About 10% of these women had received magnesium sulfate for severe hypertension. And about 94% of these women were on antihypertensive when they entered the trial. So our primary outcome was cesarean section, and we found that there was no difference in the cesarean section rate. So the C-section rate in the misoprostol group was about 32.3, whereas in the oxytocin group, it was 27.3, with a rate ratio of 1.183, and within a confidence interval of 0.9 to 1.5, and a p-value of 0.214, which was not statistically significant. We had an unassisted vaginal birth in about 66.9 versus 71.9, and assisted delivery by vacuum in about 0.8% in both the groups. So the primary outcome of cesarean section, so the rate ratio, as has been earlier said, was about in both the groups was about the p-value was not significantly different. This is something that has been shown the 3 sites that was GMC, Government Medical College Nagpur, DAGA, and MGIMS. The findings varied for the 3 sites. But there was no difference in the indications across the groups. Fetal concerns and labor concerns was the most common indication for cesarean section. Coming to the maternal complications, there was no incidence of uterine hyperstimulation in the misoprostol group, just 1 incidence in the oxytocin group. FHR abnormalities were seen similarly across both the groups, about 9.6 in the miso group and about 11.2 in the oxytocin group. There was no incidence of uterine rupture. There was about 3 cases of postpartum hemorrhage in the oxytocin group. Women did receive blood products after trial entry, about 2.7 in the miso and the same in the oxytocin. These were mainly related to management of anemia, severe anemia during pregnancy. There were about some incidences of severe hypertension when the women were enrolled into the trial. There was no incidence of seizures, cerebral hemorrhage, edema, pulmonary edema, or dialysis or septicemia. There was no incidence of intensive care admissions or deaths. Coming to the neonatal outcomes, there was a live birth in both the cases, 100% in both the across the arms. There was no incidence of stillbirth. There were 3 cases of neonatal death in the oxytocin group, but they were related to septicemia, asphyxia, and severe intrauterine growth restriction and pulmonary bleed. The mean birth weight was similar across the groups. The mean Apgar at 5 minutes was similar across both the groups. The NICU admission was about slightly more in the oxytocin group, though this was not statistically significant when it was adjusted. The days spent in the special care birth unit were similar across both the groups. So that was the safety profile for both the groups. Coming to the time from randomization to birth, it was slightly more in the misoprostol group. It took about 227 minutes from the time of randomization to birth versus 194 minutes in the oxytocin group, which was similar, slightly similar for C-section delivery, but slightly more when the women had to have a vaginal birth. So that shows a slightly increased time for delivery from augmentation to delivery in the misoprostol group, which is the blue line, versus the oxytocin group. The methods, we'll hear more about the acceptability of this study when we go into the qualitative aspect, but this was something that was part of the randomized trial, seeking the acceptability of the methods to women, and it was found that the methods was hugely acceptable. Both the methods, whether it's oxytocin or misoprostol, the method of induction of labor were acceptable for most of the women, be it misoprostol or oxytocin, and there was it was not significantly different across both the groups. So just to conclude, our study showed that continued uterine stimulation with low-dose oral misoprostol was a safe and effective option after cervical ripening with oral misoprostol. Thank you.
Thank you so much, Suchita. Right. So we get into the sort of the meat of the discussion, really, I guess. Comments, questions? Anyone got questions online? Or anybody in the room? We've got most of the people in the room know these results already. What we can do, let's just have a wait. Okay. So let's just go down to the questions. Any questions from anyone? There was a bit of a question about the safety signal, I think, wasn't there? In one thing we looked at quite carefully was because although the misoprostol seemed to be a little bit slower, and there was that very slight change in cesarean section rate, which wasn't statistically significant, but there was this increase in babies admitted to special care. And we dug a little bit deeper into that, didn't we, to see if that was a worry. But of course, the oxytocin was the normal. So were we actually reducing it with the misoprostol? But what did you think of that? Did you think there was a concern about more babies going to special care with the oxytocin?
The time they spent in the NICU was very brief. This was mainly for a resuscitation or oxygen delivery. They did not, the time spent was similar for both the groups. So it was just a finding where they went into the NICU.
Yes, the excess seemed to be only there a very short time, didn't they?
Yes, yes.
And I remember looking at the other results with regard to how many needed oxygen or intubation or any of those more. We looked at SARNAT scores and we found no signals on any of those things at all. So it just did seem to be the slight increase in admission to special care, but they seem to be fairly transient and not ill babies. Okie doke.
I think there
What
are
we got?
some
We've got,
questions over here.
The meconium, Prof. Kumaran asked what the meconium was in the miso group.
There was a concern about the meconium, and many of the babies did pass meconium, and maybe that was one of the concerns, especially in the cohort group, where there was passage of meconium and women did not go on to be randomized further because of meconium. That was a main concern, especially with the providers early into the study.
Yeah, I think we needed to go careful, didn't we? Because a lot of people, if monitoring is suboptimal, people get very anxious, understandably, about meconium passage. And if the misoprostol is causing a slight increase in meconium, then that could be a cause for unnecessary cesarean section, actually. But that didn't seem to be the case. Another question from Errol was whether the oxytocin group had infusion pumps.
Yes. Infusion pumps were used for the oxytocin group across all the sites.
Okay. What else have we got? There's a.
Can I ask about non-inferiority? It's Diana.
Yeah. Do you want to? So Francis says you presented acceptability by the women. What about the acceptability by midwifery staff and obstetricians? Midwives seem to prefer misoprostol over oxytocin.
I think that's what's coming up when we present the qualitative studies.
Yeah, we've got quite a lot of qualitative work, so we'll hear in a minute all the interviews.
Yes.
Yeah. Okay. And then somebody's very keen to please respond to Catherine Taylor's question on the quality of misoprostol. So I think Catherine's question going back was, did we assess the quality, if I remember rightly? Was there any concerns? And that was really related to the situation analysis. Were there any concerns expressed about the quality of misoprostol? And in truth, I think there wasn't. It was the Cipla is a very well-established, high-quality drug company who have been around for many years. So I don't think there are any concerns, and nobody expressed any concerns.
And we consistently used it even in the earlier study that we did during the INFORM study. So it's been around for more than 10 years, producing 25 micrograms of misoprostols.
Yeah, okay, and Catherine's saying, yeah, that's okay. Okay, yeah, we've got one question in the room. Sean, do you want to, and then we'll take that as the last question, then we'll move on.
Can you,
yeah, we can hear you, thank you.
Just a question, I don't know if you've got any data looking at the comparisons of how the women in the 2 groups were able to mobilise, because at the beginning we discussed the benefits of misoprostol is the woman might be able to mobilise, and all the benefits that we have on her labour protection and birth. So it's very difficult to look at. I acknowledge, but was there anything that you could look between the 2 groups regarding that issue at all?
That was not part of this randomized trial. That was not an outcome that we measured in this trial. But I think that something of that might come up when we are doing the interviews the in-person interviews with the women. So that's captured over there.
Okay, so hold on. We'll hear about that in a second. So thank you so much, Suchita. We really appreciate that, and there'll be a bit of time for discussion of that later on. We'll move on to health economics. So Simon Lee, who's worked with us for many years now, and when you were first a PhD student here, you first started working with us and has been doing fantastic work on the health economics. So in fact, this is hot off the press. So welcome, Simon. And let's see if we can get the slides up and running. Okay. We just need to share screens here, is that? Where's our shared screen? Why can't we share screen?
It's the PDF file, not presentation one. Oh, I already opened the PDF file. This one. Yes.
Okay. So it's open. We just need to share the screens.
PDF.
It's a PDF on
share from Zoom, please.
Where is it? It's on. Yeah.
It doesn't appear the controlling banner.
Why are we not got a?
So what did it open with? What did the PDF open with?
I think with that preview. Yes.
So.
Here we go.
Yeah. Share again. Share.
Perfect. Where is it down here?
This one. Yeah.
Okay. Oh no, is that the right one?
That's one, not that one.
Yeah, that's where are we up to? Oh no, that's Suchita Mandle's. No. Well, let's just get the sharing right. Let's try sharing again. Apologies for this, folks. We just got a brief technical glitch. Of the two PDFs. Won't you know it, that there's always going to be an IT glitch at some point here. So are you just going to change it there, Tuan? We now have it up on screen here, but I think you can't see the health economic analysis. How's that? Perfect. So I think this is, that's right at the end. That's the very end. That's the very end, is it? So we're going right down. There we go. There we go. Brilliant. Okay. So Simon,
thank you very much. I hope it was worth the wait. So, so thank you. So I'm Simon. Yep, I started an awful long time ago, what seems like, in the informed study. So quite a long time ago. So it was really nice to come back to this and see how things have progressed and see which things have stayed the same. And it was really lovely. So I very much enjoyed this. So yeah, I'm going to talk you through the health economics. We've seen the clinical. We've seen obviously what's happening on the ground. Now the actual, the numbers, the rupees. So the structure of this is we're going to run through sort of the assumptions. I'm going to compare the assumptions used in this study to the ones that we used in the informed study, just for a bit of kind of looking back and seeing what's changed. Some things have changed. We're also then going to look at our primary objective. Is it more cost effective to stay with misoprostol or to switch to oxytocin purely from a numbers perspective? And then we're going to look at secondary outcomes, subgroups. Are there certain subgroups of women who do better with one treatment than another? And by better, again, I mean purely from a pounds and pence or from a rupees perspective. Is it more cost effective to use one compared to the other? And then finally, a sensitivity analysis, which for reasons that I'll touch on shortly, is probably the shortest one I've ever done, because you'll see why with the results very shortly. But so I'll jump straight in, the methods and the assumptions. So we assumed that healthcare expenditure was done in a standard cost effectiveness template, like you'd see with any cost effectiveness study. We multiply the observed utilization of healthcare resources, which were carefully collected over several forms for all 520 women across both treatments on intention to treat basis. We got the costs in rupees for the year 2022 to 2023. So these costs did not need inflating, they were present day prices. And the analysis was purely and exclusively from a health service perspective. There were no societal costs included here, no costs to the mother, no costs to the father, no costs to anyone else who was in the hospital. It was just purely from a health service perspective. And this was the same as it was with the INFORM study. What was included and what wasn't? So obviously we started the costing from the point of randomization. Any cervical rightening, any antihypertensive treatment, anything that was performed before the point of randomization wasn't included for obvious reasons. So there was quite, that was quite, you know, quite a good chunk of costs that just disappeared away. From an induction of labour perspective, we covered the costs of Misoprostol, Oxytocin, Ringer's lactate, IV infusion kits, other medicines that are involved in the induction of labour, and there were a lot of them in Form 4. I think the Form 4s for me were, there was a great, I'm going to touch on this in a minute, there's a great deal of information in those Form 4s, so it took quite a while to get through it. From a delivery perspective, we covered things like C-section, normal vaginal delivery, repair of perineal trauma, and other operative interventions that were quite minimal. We did not cover ARM. That's in there as a typo, and you'll see why in a minute, because obviously that happened back here somewhere. From an inpatient perspective, both maternal and neonatal inpatient stay, which includes the special care unit or the ICU where relevant. Ventilator costs were also included if and where needed. And then finally, from a medicines perspective, any infection control, any antifungals, antihypertensives, any analgesics, you name it, again, big list. We got a cost for each of these, which were very kindly provided by Professor Mundley, and where not possible, were captured from other sources. So key differences compared to INFORM. Slight changes in the way that we cost up the study, which may impact how we compare the results of this study with the previous study. So food costs while in hospital were no longer costed. In the INFORM study, they were. So there was a cost attached to sustenance. This is now subsumed in the pricing structure for the care that's delivered. So it's important to bear that in mind. But the per day costs of care increased by 150% from what they were in the previous study. So that may account for some of that. General ward nursing per day was 100 rupees per day, now also gone. So again, this may start to be subsumed into that previous larger cost. Cesarean section used to be 500 rupees, it's now 1,000. So that's gone up quite substantially. Vaginal delivery used to be free for preemies. It was then 150 for second and 400 for third onwards. It's now just 500 across the board. So bit of a difference there again. Misoprostol was 3.75 precisely rupees for every 25 micrograms. It's now 17.5. in this study. So again, slight difference there. Oxygen used to be 100 rupees per day to have that delivered, to have that administered. Now it's just part of your ward stay price as per the schedule provided by the hospital. ARM doesn't matter because it was pre, but I'll put it in anyway. And epidural analgesia, easy for me to say, was 500 rupees, now 200. So you can see there are some quite systemic differences in how this has been costed, which is going to impact the continuity of how we understand the cost effectiveness between the two studies. Some assumptions: Oxytocin costed as previous, one vial basically in 500 ml of Ringer's lactate, so each costed up separately. Protein powder and multivitamins, things that were given to children after birth that were not deemed to be related to the actual process of induction, but due to obviously stage of development, these were temporarily not included. I can have these back in. So if a child received protein powder or something like that, anything to do with things that happened pre-birth and weren't anything to do with the actual, you know, the process of induction itself, I have not included. So I can have these back in very easily, just a little flick for me to stitch them back in, but at the moment they're not included. There was a slight thing in Form 4s where patient 23730, I assume, was erroneously coded as 10990 in Form 4. Just need to double check that. I may have missed that in the emails. I know there was a lot back and forth and my, you know, so if that's correct, then fantastic. Other super quick methods, because I know there's more important stuff to get onto. Form 4s were manually curated. So I went through line by line on this free text entry, looked for things like BD, TD, QD, all the different ways that you could write this and all the different durations that could be in there, and had to manually go through and match these to the treatments that we had. In the very small number of cases where doses or duration weren't provided, I had imputed these based on the modal option that I'd seen previous. So if in 99% of times the treatment was given BD for seven days, that was what I imputed as being most likely in the absence of other information, because it seemed like the most logical thing to put in. And finally, for medications where costs were not provided, I used Med India, provided the pack price and the quantity per pack, and then divided it by the daily dosage and the duration of use to calculate the number of packs used. All very basic, quite dull. Primary objective. So in terms of cost, they were exceptionally similar. There was about 60 rupees in it, which is not very much at all. And this is obviously across all these various stages put together. There was a confidence interval built around this, which I used by bootstrapping, because obviously our data was exceptionally right skewed, kind of we had some really high cost and quite a lot that was stuck over here. So they were very, very, very similar. Not much to tell between them at all. Where did these costs occur? So when we look at the misoprostol and the oxytocin arms, you can see no significant difference in the overall costs, as we would expect. Induction of labour costs, however, were significantly higher for oxytocin. Doesn't surprise us. There's more involved. There's obviously an infusion set. The cost of oxytocin itself is higher. The ringer's lactate, all of that. Misoprostol, all things being equal, is a cheaper agent up front. But that's where the differences stop. Delivery-related costs, hardly anything in it. And when you look specifically, normal vaginal delivery costs, very similar. C-section costs, ever so slightly higher for misoprostol. Operative interventions, not much in it at all. Manual removal of placenta, again, slightly higher for oxytocin. Maternal inpatient costs, very similar. Maternal medicine costs, exceptionally similar. Neonatal inpatient costs, as touched on previously by Professor Mundlake, slightly higher in the oxytocin group, because obviously there was a slightly higher usage of that, albeit for short periods of time. And again, you can see the special care unit costs ever so slightly higher, as were ventilation costs. At the moment, these neonatal medicines are not added in. The ones that were deemed to look like they were due to growth and other factors, again, they can be added in very simply, but they're not going to make much of a difference, because compared to the other things, they're very small costs. Distribution of costs. Now, this fascinated me. I've never seen a study where not only did the cost effectiveness stay the same, but the distributions are almost perfectly accurate. When you look at these distributions, they are exceptionally similar, these distributions of costs. Like the shape is almost identical. It's bar 1 or 2 here and 1 or 2 there. So there was no big outlier impact here. It's not like the mean was being pulled up by vast numbers over here, because they were roughly the same distributions across both, which was quite interesting for me. When we look a little bit closer at some of these higher costs down here, your 3,000 rupees plus, these were all exclusively and wholly down to neonatal costs. So these 6 patients had this much in terms of neonatal costs. So obviously this constitutes about a day. I think this person had been in for 9 days. So, these were quite high. When we look at the oxytocin, it was the same thing. All of the higher cost patients purely down to the neonatal stay. So we had 6 who stayed high in this group and 6 in the other who had very high costs. So again, very similar. So which is most cost effective? Well, we've already alluded to this. When we look at the overall cost and we look at the C-section rate, if you want to look at the primary outcome for the health economics, which is the cost per C-section avoided, oxytocin was marginally more cost effective, but it's not significant, obviously, because neither of the 2 constituent parts are. So you would basically spend, on average, if you looked at this at a whole population level and you said, I'm going to commit to just using oxytocin going forward, or just using misoprostol, on average, for every successful C-section that you avoid, you would pay an extra £50 to do so with misoprostol. So 50 rupees. So what's that? It's about 50p. It's very, very small. So not much in it at all. So in terms of just the first stage of cost effectiveness, when we look at the summary, while oxytocin was an average, roughly 60 rupees per patient more expensive, this isn't a significant difference. Differences that were significant were observed in induction of labour costs, but otherwise delivery, inpatient stay, neonatal and medicinal costs were all pretty much equivalent. The distribution of costs was almost equivalent as well. And while marginally more expensive, the cost per C-section avoided was lower for those receiving oxytocin, but this was owing exclusively to the slight but not significant improvement in the avoidance of C-section. So when we then look at subgroups and say, okay, is there any way that we can split this out and look a little bit deeper for different groups? Is there one that perhaps would work for different women? So what I did just to start off is I just wanted to know which groups in general were more expensive, which groups, just so that I could have a little play around there. This was just a simple generalized linear model where I looked at different groups to see where they were. And perhaps unsurprisingly, Those with a you know, an earlier GA compared to 37 weeks were significantly more expensive. That isn't a surprise, as we all know. But in terms of anything else, there were no other clear groups that stood out as being significantly more expensive. Like when we look at parity, gravidity, pregnancies, previous pregnancies beyond 28 weeks, no significant differences. So I looked for where the differences were most numerically kind of obvious. So I looked at parity. So, okay, different parity levels for misoprostol and oxytocin. Again, quite similar. This one near significance. So for those with a parity of 1, oxytocin was ever so slightly higher, nearly significant, but not quite. Same for gravidity, 2 and 3, kind of big difference numerically, but not significant. And for GA, 32 to 36 weeks, big cost difference in terms of oxytocin, but again, not significant because it's such a small number of patients, very small. So because these ones had quite big, you know, kind of significant costs, when they weren't significant, they were large, I had a closer look just to see what's going on here. So when we look at those with a parity of 1, we compare them, misoprostol and oxytocin, biggest cost differences, perhaps unsurprisingly, induction of labour, again, the upfront costs of doing it. Maternal inpatient costs ever so slightly higher for oxytocin, but again, not a significant difference. When we look at gravidity 2 and 3, again, it's the induction of labour costs that were the big driver. Neonatal costs to some extent, and for gravidity 3, induction of labour costs, maternal to some extent, again, not significant. And then finally, GA 32 to 36 weeks, biggest cost difference by a country mile was these neonatal inpatient costs. But you know, this is very much a standout. This is a big cost lever, and again, not significant. So it's worth bearing that in mind. So when we look at this from a subgroup effects perspective, there were some numerical differences in costs for those with varying gravidity, parity, and gestational age, but none of them were significant. So it shows that there's, unlike what we did previously, there was no real suggestion that we should tailor our approach for women of different, you know, different presentations. Further examination of these large differences obviously revealed no clear systemic reason for cost differences. So this led me finally to sensitivity analysis, which I originally planned to do when I wrote the health economic analysis plan for this ages ago. I thought there's no way these two are going to be so similar. So we should get some really interesting sensitivity analysis where I can play around with things and see, oh, what if we could make them more similar? But because they were so similar, it makes it very difficult to do a sensitivity analysis, because the whole point of a sensitivity analysis is to say, how can we get these things to be more similar? What would have to change? So in actual fact, the only thing that I could do to make them more similar was to say that if we wanted the costs to be exactly identical for the two, and not just, you know, currently they're not significantly different, but to make them exactly identical, the cost of misoprostol will need to go up from about 17.5 rupees to 51.79 rupees. That was the only way that they would be exactly the same. And this is it. I can't do much more because they're already so similar that there's no point in playing around saying, what if we change that? What if we change that? Because we've already hit our endpoint with sensitivity analysis of them being no different. So for a sensitivity analysis perspective, there wasn't a great deal more I could do with this. And I'm more than open to suggestion. If anyone has any great ideas that they think will be useful for the paper, I'll happily throw them in. But for the moment, I'm at a bit of a loss as to where to aim with this sensitivity analysis, because it's quite rare that you get two that are so similar on every front. And that is that. So thank you.
Thank you so much, Simon. Fascinating. Yeah. Comments, questions, things to let's see if we can just open the chat here and have a look. Tuan, can you see the chat there? I don't seem to be able to see it here somehow. Let me pick it up on my. Get it on my phone, perhaps. Okay. So just one comment from Antonietta Medina Lara, but yeah, agrees with the analysis. Is a health economist from Exeter. Brilliant. Well, thank you so much, Simon. Really appreciate it. Actually, that we're running a little bit behind, so actually that's not a bad thing that you've kept good time. Thank you. Okay, so moving on with the with the presentations and move on to the qualitative. There's been quite a lot of questions about what do people think, or what is available, and what do the staff think about. And Jaya Tripathi, who's assistant professor in community medicine from AIMS in Nagpur, is going to talk us through our qualitative results, which we did alongside the study. Jaya.
Thank you. Share this one. Okay, so hello everyone. Very pleased to be presenting the results of the qualitative exercise that we did alongside the main MOLI trial. And I'll be talking about the experiences of women who underwent induction and as part of this qualitative exercise. So this was an alongside qualitative study which went along with the main MOLI trial. And this provided a women a platform to describe or share their experiences of induction. We've had minimum literature about women sharing their experiences of induction from low middle income countries, although we have some evidence from high income countries. So this is one attempt to present how women experience induction and childbirth in India. The aims were to explore patients' perceptions, expectations, priorities, their understanding of, and their concerns around induction of labor, to explore their experiences, acceptability and satisfaction of patients after induction, to better understand the feasibility and acceptability of different induction regimes from the healthcare professional point of view, and also to explore potential barriers for implementing research findings into practice and suggest potential solutions. Now, as part of this exercise, we did 53 semi-structured interviews with women pre and post induction. We also carried out 8 focus group discussions with healthcare professionals, which included doctors, nurses, and the research assistants who were part of this trial. And these interviews were mostly done in local language, Hindi or Marathi, which is as per the convenience of the participants. So focus group discussions were done again before trial and mid-trial, whereas these interviews with women were done pre-induction and post-induction. After going through the transcripts, we could find out 4 major themes: induction of labor methods, induction in childbirth as part of one of the wider experiences in life, key moments in childbirth experience, and the impact of the study. We'll look at one by one these themes, and the first one is induction of labor methods. There were some concerns around use of MISO from the perspectives of healthcare professionals, mostly revolving around hyperstimulation of uterus, fetal distress, meconium, especially with when the number of doses go beyond 3 or more. So there were some concerns around the use of MISO, and as a doctor in a focus group said, Misoprostol contractions, it can lead to more contractions, and we have no time for observing their contractions. So especially in a setting where there is not much of monitoring, there were some of these concerns around the use of MISO. In terms of the providers, providers felt that women would like oxytocin more than MISO. The fact that when you give something through your veins, there's a big psychological benefit that something will work, so pain will start. So that's the provider's view. They felt that women would like the IV route oxytocin compared to the oral miso, and then say, so a nurse said when we apply pitocin or oxytocin through the IV, they were like, got the power or got strength. So more of a psychological benefit. But if you look at the patient's view of which method they preferred, I think there's not, it's not very clear that. So they were basically in three groups. I would say there were like three groups. The first group of women preferred, obviously, yes, the IV route, again, because of the psychological benefit that if something is injected through the veins, it starts acting quickly. There was another group of women who preferred the oral miso because of they could be mobile, can be with their relatives throughout the process of induction, easy, no needles needed. So that was the second group. And there was a third group of women who were not really concerned with the method of induction, and they felt that it's the doctor's decision, and that I rely on the doctor's decision. They know what's best for her. So as a postnatal woman said, not everyone's body is the same. The pill was suited to me. It's not necessary that it will suit her too. So they relied more on the doctor's decision, which method of induction will suit him or suit her. If you look at the second theme, induction in childbirth, one small part of the wider experiences in life. Family is very important for all women, and especially when it is pregnancy, it is more so because the whole family is involved in the process of pregnancy, childbirth, and delivery. And then everyone will care for and love that baby, and everyone will say to me that it was great, means my in-laws will be very happy, said a prenatal participant interview. So that says the importance, states the importance of family who is really involved in the whole process of pregnancy and childbirth. Of course, the major theme that emerged out of the transcripts was the centrality of the baby. The health of the baby is of primary concern for the mother, is irrespective of the method of induction and the method of delivery used. So this was the central theme. The centrality was the baby's health, and the patient's whole worries, concerns were all revolving around the health of the baby, and not really on what was the method of induction used. I was trying and I was praying to God that my baby's life should not be in danger. So it doesn't really matter what method of induction you do, but as long as the baby is safe, she's happy. And as we say that the baby underpins the entire process of induction and childbirth. Even though Caesar happened, whatever happened, the most important thing for me was my baby girl. I have her safe and sound. However, there was some preference for natural birth by some women. They wanted to have natural, normal vaginal delivery. Trouble for 2 hours rather than trouble for 2 months or even a lifetime was expressed by one of the postnatal women. So there was some preference for natural vaginal childbirth, of course. Key moments in the childbirth experience. Agonizing pain, the induction labor pain was quite long, agonizing pain expressed by most of the women. And as somebody said, induction of labor means like rebirth. It means we feel as if we are going through death because the pain is so intense. So quite long, agonizing pain was one of the key moments in childbirth experience. Second one was very interesting. Vaginal examinations, they came out without any prompt, and some of them even experienced these examinations as the worst thing in their life, the worst experience, very embarrassing, painful, and associated with fear, pain, embarrassment. So came out unprompted from the women, from them. So I was afraid, and again, they suddenly do checkup, don't behave properly, they assume we are like machines. It came out quite strongly from these transcripts. One interesting thing that also came out is with proper counseling, this embarrassment as pain, I think, was a little lesser than doing suddenly doing a checkup, a vaginal examination without proper counseling. Women valued the relationships with healthcare providers. They felt they valued the efforts by the healthcare providers in giving them a safe and sound baby. They valued the care that they received from the healthcare providers. As a postnatal participant said, they tried a lot. I respect their efforts because they tried hard for me. There's no doubt about it. So they really valued the relationship and the interactions with the healthcare providers. If we look at the impact of the study, women were happy to share their experiences with us. They felt important to be interviewed and to be sharing their experiences. By listening to our feelings, it's a good thing. It is very good for the ladies like me. They can share their feelings. For women who have family pressure on them, it will be better. If we look at impact on counseling, there was quite a shift of the perceptions of the providers. Earlier, pre-trial, providers had this view that women would not be able to understand counseling regarding methods of induction and method of delivery. So this view from the providers' side that women will not be able to understand shifted after the trial. They now feel that counseling is of help to women. We must counsel women on the method of induction used, their advantages and disadvantages. So there was a good shift in their opinion pre-trial and post-trial, especially related to the use of counseling. Now they say they understand if we explain them. If we explain them with love in labor room, then they understand. Okay, this is a nurse stating during mid-trial focus group discussion. Implementation of protocol, yes, there was quite reluctance in using MISO, because there was reluctance in terms of changing their standard practice. They were very much used to MISO and Oxytocin during augmentation. So suddenly changing a practice is difficult. So there was some reluctance to change from Oxytocin to MISO. And it still is there, but I think they also expressed that with evidence from trials like these, the reluctance will go down. So it needs evidence from credible research designs like RCTs, and in that case, this reluctance might go down. As a doctor pre-trial said, that even if 3 doses are given, the findings are same, it's meconium staining. So this is the standard practice and the norm and the feelings around the usage of meconium beyond 3 doses. So there is some reluctance to change, but I think with evidence, it might go down. To conclude, the baby's well-being is the most important concern for the women, irrespective of the method of induction used, as against the clinician's view who felt that women would obviously go for the IV Oxytocin. Implementation of protocol can be affected by concerns over MISO, and of course, there is a reluctance to change from standard practice. There were some key moments which could impact positively or negatively the whole experience of induction in childbirth, but could be influenced by clinicians if we really counsel mothers well before performing a vaginal examination. If we use obstetric analgesia to take care of the intense labor pain, and if we interact with the patients in a much nicer way, I think clinicians can influence these key moments during induction in childbirth. Women can understand what they need about induction and want to share their experiences, which again states the idea of counseling women during the whole process of induction in childbirth. If you look at the implications on practice, we recommend proper induction counseling to be provided to all women undergoing IOL. Vaginal examinations are frightening and painful, so it should only be performed if necessary with clear, caring explanations and counseling. Trial protocols can be affected by with ingrained concerns or with standard practice, which could affect study results and go a wrong way, and need to provide credible evidence if we have to change the standard practice. And alongside, qualitative studies are invaluable in providing insights into participant experiences, and we recommend such alongside qualitative studies in further RCTs. Thank you. Thanks.
Thank you so much, Jaya. That's fascinating, and maybe a bit of a wake-up call for those of us who are clinicians. It's sometimes sobering to hear directly from the women in a situation where they can talk freely. Any comments, questions online? Anything coming up or from the room? Yes, a question at the back from Simon.
Thank you. Loved it, by the way. Really good presentation. Quick question about you mentioned the clinicians' concerns about not wanting to deviate from what they know. This is the protocol that we use. Was there any indications there of what would need to be provided to clinicians in order to allay those concerns, to make Misoprostol more, kind of acceptable to them? Was there any clear indication of if this was provided, if this didn't? See what I mean? Like the ranking of those actionable things that could be done.
I think yes, there was reluctance to change from standard practice, but they knew that this is done as part of a trial. But using Miso in routine practice is certainly a big no for most of the practitioners who use Oxytocin. But being a part of this trial, they knew that this is new and part of a trial. Of course, they looked for more evidence on Miso, on any previous evidence on Miso, use of Miso in previous studies, and all. That was the thing that I looked for. It is some existing evidence on how Miso works. Yeah, that's the only thing I think they'll be looking for that.
Okay, thank you so much, Jaya. Much appreciated. We better move on because we're running a bit short of time, a bit behind, and we're going to finally finish with Rachel Howard, who's one of our medical students who's been working with us. We developed, as part of the study, a new way of trying to look at outcomes, which somehow crossed cultural boundaries and which we could use easily in India, where women themselves defined the questions. So, Rachel, thank you very much for coming to speak, and I look forward to hearing from you. If have we got okay, perfect. Thank you.
So thank you very much for having me. Sorry, where can I see the slide? Oh, okay. I can't see it on the screen. Like that's very.
That's there. If we go to.
Oh, amazing. Sorry.
There we go, and then just down.
Yeah, brilliant. Perfect. So nice to meet everybody. My name is Rachel. I'm one of the medical students that's been helping on this project. So the main purpose of this talk is to introduce the pages index to you. I have included a couple of results just to demonstrate how the tool can be used, but the main focus of the talk will be introducing it. Oh, sorry, I didn't know the microphone's there. So I'll be introducing the pages index. So why bother with a new tool? What's the purpose of it? When we're doing clinical research, we not often ask participants what is important to them, or whether we're trialing new interventions. We don't often ask participants what do they think about the new intervention. Is it acceptable to them? And when we do it, we often do qualitative interviews. Problems with this, though, is it provides usually a very small sample of all the patients involved. This sample may not be representative of the entire cohort, but the benefits are it allows participants to discuss their issues or their priorities in a lot of detail. One of the problems, however, if we use questionnaires instead, which allows for a much larger sample size, is that the questions themselves are often written by the researchers or by the funders. So they don't necessarily reflect the priorities of the participants involved in the trial. So what's the alternative? Well, the alternative is something that is generated by the participant or the patient themselves. So this is our patient-generated experience and satisfaction index, the PAGES index. What it involves is asking participants before they have entered a trial, whether that is for induction of labour, whether that is for trialling a new cardiovascular drug, what is important to you, in this case, about birth. So participants were able to state freely up to 8 statements about what is most important to them. In cases where we've done qualitative research in the past, we usually then stop at that point, so we know what 8 things are most important. The PAGES index, however, takes this one step further, is we give participants 20 counters or the number 20 and ask them, of those now potentially 8 statements that you have made, which of those is most important to you, or please reflect essentially the relative importance of each of those statements. So now we not only know what is important to them, but which of those statements is then the most important. After the trial or intervention, or after birth in this case, we ask the women the exact same question. And this time we again get them to identify their areas, rank their relative importance, and then also ask them, how satisfied are you with this particular aspect of your care or of birth in this case? And you can rate it on a scale from 0 to 10. So who did we do this for? Well, actually, we've done this on all 1,033 participants in the cohort and in the randomized aspects of the study. So we have a significant proportion of data, what's important to women about birth. But for the purposes of this, I mentioned that we've done it for the 520 involved in the MOLI RCT. So what we did, they completed it before and after birth in their native language, in Hindi or Marathi. Depending on literacy levels, research assistants were able to support the women by writing the statements on the form for them. And then it was very kindly translated, which I know was a lot of work for one of our translators. And then it went through data cleaning and started the analysis from a qualitative and from a quantitative point of view. So I thought for ease, it's probably most sensible if I show you one of the forms. So we've got a form here from an antenatal participant who has been asked to list up to 8 statements. So in this case, we can see that the participant has chosen to list 8 statements. And then we know that in this case, the participant wants a vaginal delivery, that they're anxious to do with their blood pressure, and that this idea of family is very, very important to them, and pain, just as the same sort of results that are coming out in the qMOLI data that was just presented. But now when you look at the beans, what we can actually see, or the counters, is that of those statements, having a vaginal delivery is by far the most important. They've allocated half of their tokens to that one single statement. But you can also notice that not every statement has to be scored at all. So if a participant has reflected 8 things that are important to them and then is asked to rank, you can kind of reflect again and think, well, of those, really, which is the most important? Or potentially, like with the medications, for example, maybe that's not as important in the context. So example of a postnatal form, again, we can see in this scenario, the participant has chosen to make 5 statements. So they haven't chosen to fulfill all 8. But in terms of distributing their tokens, the fact that they've got a safe baby and they've got a baby girl was by far the most important to them. So we can see one of the statements here, for example, I did not get any pains at all, that's why I had to have a C-section. We've got this idea of having a section to this participant, but we can see then on the satisfaction scores that they've rated that as 0. So actually they were not happy that they had to have a section. They would have preferred a vaginal delivery. But when we think about then the baby girl that's just been born, that is most important. So even though they were not happy with the method of delivery, overall, it still didn't outweigh the fact that they've got a safe, healthy baby. So in terms of analysing this data, we have split it into the qualitative aspect into codes, sub-themes and themes. So just to touch on a tiny bit of the results to give you a flavour of what's been going on. We have 6 overarching themes. So this idea of perspectives on the birth, whether that is the pain associated with birth, the method of birth, perspectives on the baby, most commonly talking about that they want the baby to be healthy in some way. And then the physical and psychological condition of the mother. So whether she has any other symptoms at the moment, any swelling in her legs as a result of the blood pressure, and whether she's worried or anxious. And then this idea of family, again, being a very common theme, and also looking to the future. So just to show you the perspectives on the birth, to show you the types of codes that are coming up, we have the antenatal on the left-hand side and the postnatal on the right-hand side. So we can see that actually the same codes are transferring from antenatal and postnatal. We do have some that are obviously different, but the vast majority tend to be equivalent, between the two. And this is a very small flavour of what can be done with the quantitative. My involvement in this has been mainly the qualitative aspect, but just to touch upon the quantitative, we've looked here to see what was the mean number of times that the overarching themes have been mentioned, and were they different between antenatal and postnatal. And we can see that for nearly all of these, there was no significant difference between the number of times the psychological condition or the family was mentioned between the antenatal and postnatal form. But what we can see is the looking to the future, actually it's statistically significant, and it comes up far more commonly in the postnatal form, which you would expect once you've kind of got over that idea of birth, you've got your healthy baby. Now you can start looking to the future and thinking about the education of the baby, vaccinating the baby, things like that. So the Pages Index has allowed us to establish what was important to all women involved in the randomized control trial, and the 513 women involved in the cohort aspect of the study. It allows for both qualitative and quantitative data to be collected. And we concluded that it is a feasible tool because we've done it, and it was acceptable to the women. So I believe in the qMOLI data as well, there was a question about whether the Pages Index was acceptable or not, and it has come out to be acceptable. And I'd be glad to welcome any questions as well, or comments if you have any.
Thank you so much, Rachel. It's fascinating. And in fact, the more we go into this, I think the more we find there is to explore in the data. Any questions before we move on to the panel discussion? We can actually bring up questions as we go through, but thank you very much, Rachel. Appreciate it. What we'll do is we'll move on to the panel discussion now, and there may be questions which come up around the Pages Index. I'm just going to move to a different position to make it a little bit easier. So we're delighted to have a very prestigious panel with us, and thank you so much to our panel for helping us out. I think the panelists probably don't need any introduction, but Professor Sabaratnam Arulkumaran is speaking. Everyone's online here. Former president of the RCOG in Vigo. We've also got Professor Andrew Shannon, who is in fact chair of our steering committee and is professor at King's in London, and then also Dr. Moushami Tadas, who is principal investigator in India of the study, to give us something of a flavour of what was going on sort of on the ground. So I want to, Arul, can I turn to you first? What do you think are the implications of this research to others? I mean, clearly this was conducted in India. Do you think this is applicable to other places around the world?
Well, I think it's a good study, original thought.
You're not getting any, I'm not getting any sound, Arul, at the moment. Has anyone got?
My microphone is open, so.
We're getting sound.
Okay,
sorry, carry on, please.
Thank you. It's an interesting and an important study, Andrew. I think there's no question about that. The issue is actually not only we are looking at success in terms of cesarean section, because that's the end point you took because of a small study. But we had to look at the implications in terms of what will be the neonatal outcome in the two methods of induction, because we know that the incidence of HIE, for example, is much higher, about 10 per thousand in India compared to 1 to 2 per thousand in the UK. So it has much major ramifications. So it has to be really studied in large numbers to see whether it has an impact on the neonatal outcome. One of the things I would be interested to know is actually of the 1,000-odd women who are recruited, 500 went to the study, but there were a cohort, which is about 500. And not all of them would have fitted the exclusion criteria. And what was the reason why they were not included? And I'm just wondering whether it might be because of meconium staining of the like at the time of spontaneous rupture or induction. So that, in other words, when we publish or something like that, the question will be asked, why was the others not included in this study? And what happened to the babies in their case, and what happened to their, were they continued oxytocin, or did they have misoprostol, and what happened to the delivery, and what happened to the neonates? Thank you.
Thanks very much, Harold. I mean, I can answer some of that question, which is that, of course, we recruited 1,000, and then it was only those, some had a cesarean section before they got through to rupture of membranes. But there was another whole other group who actually, once the membranes were ruptured, off they went and gave birth vaginally, and they didn't need the augmentation. So in truth, this is quite a narrow group we've got here in the randomized trial. They're not only hypertensive, they're not only started out with induction, but then have needed artificial rupture of membranes, and they've then needed augmentation as part of that. So it's about 50% of the total, but we have got the cohort data, which we're going to be analyzing as well. It'll help us to work out that meconium question, because actually within this small group, there was no difference in meconium, but of course they'd all had oral misoprostol prior to that, so it could come out in that earlier data. But thank you. Andy, what were your feelings? Do you think that there's implications of these either for Indian births or for births around the world?
Oh, absolutely. I mean, I love these pragmatic trials, Andrew, and congratulations to the whole team and yourself for pulling it off. They're not easy, but I think doing it in the places where the outcomes are more prevalent tells us a lot. I mean, I'm a great believer that humans are humans, and you can't just say you've got to do a trial everywhere in the world where you apply an intervention, but you need to look at the generalizability and the implications in the different areas, and actually this reciprocity of learning from a place where outcomes have more prevalence, and saying, well, therefore it must be applicable anyway, but you just can't detect it. This is more of a methodology issue rather than a sort of biological issue. So I think, yes, that there's a lot to be learned. And if you see that something works in an area where there are worse outcomes and you can detect them, there's absolutely no reason not to learn from that and say the opposite is true. You can actually use it elsewhere with benefit. The thing is the generalizability, and there are some really reassuring things in this trial. You know, the fact that you can have 500 people and then there's not a single rupture, there's virtually no hyperstimulation, that's applicable everywhere and anywhere. And I think you can gain a lot by saying, look, this is a safe alternative anywhere in the world. I think the issue is rather like you have a certain quality within a clinical trial. You have good staff, you have good integrity of governance, etc., etc. What happens when you go out to perhaps those parts of the world where things aren't as good as your trial centers, where things aren't as monitoring? And you can say that it's very safe, but you do need to look at the implications about things like, do you have infusion pumps, etc., etc., in the trial sites? So you have to be a little bit cautious with your generalizability, but there's definitely a lot to be learned, if that answers your question.
No, thank you. It's interesting. The hospitals where we worked in Nagpur are a very interesting site, because although they're government hospitals in India, they're very high quality government hospitals in India. And Suchita and the team in Nagpur have done a huge amount of work to improve get the quality, high quality there. But we did also use infusion pumps, and it was interesting that in the situational analysis, actually, although use of oxytocin was ubiquitous, everybody used oxytocin, only 50% had infusion pumps. And that's when you get into some of the dangers. So it seemed to us that this was quite a good setting to study it, because it has some of the features of higher rates of poor outcomes, but it's also got some of the features of very high quality care as well. So the question would be, now, can you move it into the top private hospitals or in Western settings, or indeed could you move it into settings with relatively poorer standards of care? Moushmi, from your point of view, Dr. Salas, you were working as the PI in the study site. How was it received there? Did you sometimes in a study it's a fairly new concept, and then people go, oh, actually this works quite nicely, and others people are still quite hesitant at the end of the study? How did things change as you went through the study?
Changed in the terms that using the number of misoprostols, like initially they were very hesitant in use of misoprostol, like number of misoprostols, like how can we give more than 5, how can you give more than 6, how can you give more than, like, so now the people, they are more acceptable. Acceptability to misoprostol has increased, like when the results were seen that the patient can deliver without the need of oxytocin infusions. The only concerns, like in this situation, were like fetal concerns, right? When the patient may get hyperstimulation, the patient may have fetal heart rate variability, the patient may pass meconium. In our situation, in our labor rooms, our NICU setups, because of the number of patients we have, like apart from the hypertensive women, there are other like high-risk women, the load is so high that there are concerns regarding the monitoring, right? And for fetal aspects also, like the NICU is also overloaded. So as sir has already said that in our Indian setup, the rate of HI is very high. So when we look for those aspects, so there are really concerns. But as from the first study which was done at GMC Nagpur and the second study which we did, the MOLI study, which we can clearly see the difference. There is more acceptability for oxytocin. And as we have more gadgets for monitoring, like we have fetal monitors, CTG machines, continuous monitoring, fetal monitoring. In the trial also we had, and now also we have. So the only crux of the story is that intense fetal monitoring is required whenever we are using any type of induction of labor. So even if the fetal like labor rooms, they are very heavy and very busy labor rooms, but fetal monitoring is very important. So that is the main issue. So like misoprostol, we are using it, but with intense fetal monitoring. Of course, with oxytocin also, we require fetal monitoring, and any sort of induction we are doing, fetal monitoring is the main concern over it.
Yeah, thank you. One of the questions, sorry, Andy?
Yeah, can I just make a comment then, because Moushmi makes some really important points here. Obviously, if you have an intervention and you have a poor resourced area, you have risk, and everyone says, well, there is risk. The thing is that if you have a randomized trial and one thing is less risky than the other, that can only be a good thing in a low resourced area. One of the things I really love about this trial is you've shown that something that has reduced complexity is equally as good, and anything that reduces complexity can only help safety. And therefore, you know, you say, well, you have poor resources, but in the context where you have to do inductions for very serious reasons and you don't have monitoring, the paradox is it's better to do, you know, one thing than the other, and you've kind of proven that, which I think is great. Yeah.
No, thank you. Errol?
Well, I think I just taking from what Moushmi was saying is actually, if I take figures from South India, which I am a little bit more familiar, the section rates are high. They are about 40% section rate, 35, 40%, but yet the HI rates are high, 10 per 1,000. So, and they use oxytocin, but without an infusion pump. So my explanation to that is actually, if they keep a gravity fed with the arm stretched, and if they turn the arm one way, it doesn't flow. So they do a section for failure in progress. And if we turn the other way, then it flows too much, and then they get the fetal heart high and they do a section. So if you can avoid, like Andy was just saying, a lesser complicated method and yet achieve the same result. I mean, fetal monitoring will apply to both sides, whether you're on misoprostol or oxytocin. But with the misoprostol, if you don't have that infusion regime variation, unless you give oxytocin pump to every single laboring woman, then the current trial indicates that it is safe to give the misoprostol for subsequent augmentation after the initial thing.
I mean, it's interesting. There's a comment in the questions. So Alice Cotter says, it would be interesting to see the same study done in a hospital in India that doesn't have infusion pumps or monitors or monitor with CTG, as misoprostol may prove much better than oxytocin in this setting. And in fact, we considered doing that, but it didn't seem ethical to do that. From an ethical standpoint, we need really to give the best value of care that we could do. So in fact, we specifically chose sites where there were infusion pumps. And if there was a site which didn't use infusion pumps, actually we would have put them in to keep it safe. But it is very reassuring that hyperstimulation in the two sites were the same, even though you had the good infusion pump. So even with perfect oxytocin given their equivalent, so it can only get worse from that. Okay. So Moshbi, where do you think we can go on from here? I know in terms of spreading out, and we're going to be talking, in fact, the group who are here, about dissemination moving forward and what implication this has for other hospitals around India. Do you think other hospitals might take this up? I'm thinking especially of those hospitals where there's few infusion pumps or lack of CTG monitoring. Do you think there's promise there?
Yeah, these like results or these can be taken up by hospitals, by smaller setup hospitals, I think. So they can take over it, where they really induce the patients wholeheartedly, right? And they have a full like 1-to-1 doctor-patient ratio. So the monitoring is proper. So in such setup, I think so it can be very well accepted. I think so. That is the thing, because in any set of kind of induction, monitoring and fetal concerns are there. So it can be taken up by like smaller setups, as far as I feel, right? Because the concerns are more for misoprostol, like if with one single study which we have done, right? So people may not be like acceptable unless they use it. So they have to use it, they have to monitor, they have to use the CTG for fetal monitoring, they have to use the, if they are using misoprostol. So they have to have monitoring facilities and 1-to-1 doctor-patient ratio. And they should have acceptability. And it can be used in smaller hospitals, like small setup hospitals. So I think so in such setup, if they are acceptable, and it can be used very well. And in general hospitals, there will be concerns, although it has acceptability in terms of oral use. The patient is not restricted to her bed due to oxytocin infusions, and oxytocin has issues for storing facility. Refrigeration is all there. These are all the concerns for oxytocin. But for misoprostol, these can be used if the acceptability is more in smaller hospital and monitoring facilities, they are more. So it can be very well used.
Okay. Andy, do you see places where there might be low-hanging fruit, where this might be particularly, because it may be that everybody might say, yeah, this is right for us, but there may be other places where you say, actually, this has got a particular advantage in this setting.
Yeah, I mean, I think the problem is going to be convincing people that it's okay to use, because everyone will have their biases and worries and previous experience. And somebody's made a very important comment in the chat about saying, "Oh, how do we know that this is safe and standardized and all the rest of it?" But the other side of the coin is, how do you know oxytocin is safe and standardized and all the rest of it? And if you actually compare the two, the likelihood that one goes wrong is more likely with oxytocin because of its storage difficulties, because of its infusion, and you know, just giving it in the correct way. It has that more complexity. So if you had to pick between the two with all its possible foibles, Misoprostol to me is a safer option, even if you sometimes get it wrong. And you always have to think that. I mean, there's a classic case of the tranexamic acid, which obviously is an incredibly good drug, but when people started using it, it got mixed up with bupivacaine ampules. People started to give them accidentally and started killing people. And that's when complexity is greater. The thing I like about what you've done is you've moved away from the ampules, the infusion, the storage, into something that's less complex. And therefore, it must be safer, even with all these concerns about, is the quality of the drug okay, et cetera, et cetera. So in answer to your question, my view is that there's going to be a long phase of education, but this is a definite alternative everywhere. And people will learn from experience and realize it is probably a better option.
Okay. I'll come to a final question. There's a question online here from Renee Stafford. And she's worried that because we're simplifying the protocol and because it's making it easier and safer, is this going to be an example of another too many, too soon problem? Is this making things so easy that we could get overuse? In truth, in the same way that there's a lot of studies showing that oxytocin has that same problem, with large numbers of births sort of unnecessarily augmented with oxytocin. Is this too easy? Errol?
Well, I think the drug, when it is available, then anyone can use it. And misoprostol, of course, if it is going to be given orally, then nurse or midwife or doctor can take it, whereas to prepare an infusion, they have to take the vial, break it, have an IV, and so on. So it's much easier that way to dish it out like a chocolate or a toffee or something like that. But I think in carefully controlled situation where everybody knows, that means there's a importance of high education and training, which goes with the use of this. And I also would like to emphasize that when you think about the trial, it will be good to have the results from the cohort and also publish it somewhere or along with the trial, because otherwise there's always a misconception you're hiding something from the rest of the cases studied. You know, it's like an admission CTG by Lawrence Impey some time ago. They started with rupture of membranes. Only if there was no meconium, they randomized it. And they showed no difference. So, and the rupture of membranes were less than 2 centimeters. So they will think there's a catch if you don't really give the results from the cohort. So I think it'll be good to do that and then convince that this is a safer drug, easily available, no refrigeration. The drug will be standardized. And of course, as Moshni says, you have to go with monitoring hand in hand.
And Moshmi, do you think this could increase the rate of sort of inappropriate augmentation? Do you think there's a risk there?
Yeah, there is, of course, initially when misoprostol was introduced, there were many misappropriate uses of this misoprostol, like just pushing into the vagina, or putting it into the in the evening rounds when the PGs came, they used to put it, and then the patient who used to go in active labor. So like under the cover, it used to happen initially when they were inductions of labor and all, when initial phases, when initially misoprostol was introduced. So but now over the years, this use have been decreased, and more proper use of misoprostol have come up. But over the when it becomes too familiar, sometimes it happens, no, that you tend to use it more often. Yeah. So it may happen. So if it is more introduced without any monitoring or without any proper knowledge of the drug, if it is used. So training, like Sir has said, training is more important for the use.
I mean, I thought it was interesting actually and it shows the beauty of doing qualitative research alongside main research, is that actually clinicians, far from being gung-ho and being very enthusiastic, were sort of, whoa, go really careful, because actually they're used to using the very excessive doses or experiences of people using. So actually people were extremely cautious with it, which in a sense is reassuring. That you don't want people to be too enthusiastic and be handing it out like Smarties. Andy, any?
Yeah, I mean, I agree. We've got to be very careful with mission creep with any intervention. You know, there's plenty of examples in our profession ever since the days of CTG, you know, and more recently with things like PLGF. You know, people just think, oh, this is good, let's start using it. And then they start using it outside the criteria where the proof of benefit is, and the risk benefit is sometimes not always good. Even antenatal steroids, you know, get used too much because everyone thinks they're good. And the risk benefit of any intervention you've got to look at carefully, and we have to be brave and say, this is the evidence, this is a group that benefits, and not to just go wider afield because it's easy or cheaper or simpler. Obviously, you can do the trials in those populations that are easier, simpler, cheaper, or whatever, but you've got to get the evidence before you start putting it into guidelines and making recommendations.
It's interesting, there's a few comments online about being careful about submission creep as you describe it. And it's true, and it's always been a question over misoprostol. Is it better that actually people are inducing labor with all sorts of things, with oxytocin infusions, which you can't regulate. They're inducing with herbs. We see a lot of that in Uganda with pretty drastic consequences. Actually, if you've got something safe, at least at least it's a safe version of doing it. You don't want to encourage people to do it, and you need to get the training right. But I'd rather people did it with something safe rather than with something unsafe. Okay, so we've gone a little bit over time. Thank you so much, everybody, for joining the panel. We appreciate it. Especially we've got a junior doctor strike here in the UK at the moment. So I think, Andy, were you just assisting somebody there?
No. I was actually doing an operation, would you believe?
Were you?
I did all right, don't worry.
Most of my colleagues are all being pulled in and working as assistants and going and clerking patients on the wards. So thank you so much, Andy, Arul, Moshmi. We appreciate very much your time.
Thank you so much.
Thank you.
Congratulations,
everybody who's joined in the room and online. The papers are in production and they will come out, and we'll share a summary of the data that we've got to everybody who signed up for it. So thank you very much. Have a very good morning or evening or afternoon, depending on where you are in the world. And thank you for joining us this afternoon. Okay, bye-bye.